So good afternoon. The VA services roughly around 9 million veterans through 300,000 healthcare professionals, servicing an area of around 1,245 hospital centers and 170 medical facilities themselves, servicing these folks that are in a split of 85% men, 15% women. All of these individuals either have financial hardship or have serious injuries that limit their capability to either work or function totally and completely as a complete individual. Of note, we have a research and development service within VA that's at this point 90 some odd years old. We have 4 services spanning general areas of preclinical work, clinical sciences, that includes also clinical trials, health services, that is to how does one deploy the information and the techniques and technologies into the clinic itself, and rehabilitation services as well. VA research has done a lot of very interesting things, and it has spanned quite a while, as I mentioned. We were actually one of the first that started off a clinical trial looking at streptomycin for tuberculosis, the dark ages, as one would say. We developed the CT scanner. We looked at the nicotine patch. We have done a lot of different things. We have even one investigator by the name of Gleason that came up with an idea of looking at a nice little article looking at prostate cancer, trying to develop a grading system that we still use despite modifications. The latest thing that we have is the Million Veteran Program, having nearly 600,000 individuals on board and doing genetic testing on these folks too. What's important to stress within VA is more than half of the researchers that are in the system itself, and we have around 2,000 active studies ongoing, are clinicians. So physicians, they're psychiatrists, they're psychologists, helping to develop techniques and understanding of the medical sciences to move the science forward. Getting to some of the points, one question was, please specify what type of research results should or should not be returned to the participants. We don't return research results to the participants if they are not clear grade. It's just the way within the healthcare system that we do. We assume that there are better ways of getting the information conveyed out. Publication by the investigators into general journals, augmentation in the healthcare that is being provided within VHA, Veterans Health Administration. There are, under some protocols, the ability to go ahead and submit, and actually a good number of individuals do, pamphlets to the research participants on a status of where they are in the research, what are the final developments that this might help to give an individual. But de facto, research results are not brought back to the person. Now there's a flip in this whole thing too. Research and development is under Veterans Health Administration in a very close, tight line and runs under HIPAA. So any research that ever is done under VA is under the designated record set. That's an interesting point because despite having a consent saying that we will not return research results to you whatsoever, thank you very much, and if you like it, great, if you don't, that's okay too. A participant could potentially, under HIPAA, request information specific to them for their own need. The way that also works is that the research participant would need to state what they want to have and have the clinician, that is the investigator, explain what this means at a level that both understand. I think in a nutshell, the question really comes down to who wants what, and are we capable of explaining it in a cogent manner that everybody understands where everything is, given the science and the state of the understanding of medicine itself. We do also have another point in this, that because clinicians are functioning in the research realm, they do take results. So as an example, you have a patient that is in an outside clinic, has some blood work, and they are now participants within this VA study. If I do find out as a clinician that this person has a low platelet count, I do put that information into the medical record, despite this is not a piece of information that is de facto from VA. Now, there's also the other point that under the research protocol and whatever the IRB assumes as being appropriate and the investigator agree upon, that the incidental findings themselves, if there were to be something, and at what level and what type, would we want to go ahead and convey that to the given individual, and in which manner? Would it be a written form? Would it be a oral form, or whatever that may be? So there are these caveats, because you are a clinician, to put that information in the record and relay that to the patient, because the patient is a patient of yours, and you are the research investigator of that patient. What results should be returned and at what time? That all depends also on the given question of is the investigator knowledgeable enough to talk about some of these points, as well as is the participant actually asking for those specifics. They could get that information, again, because this is riding under HIPAA. Who determines how to report the research findings? This is all through the IRB and all the regulatory statutes that are stated in that, and how that is to be divulged. That's the way we run with that as well. There's the question about what would be the financial implications of a systemic clinical validation of a research results. And here is where research and development actually does function under VHA and develops new technologies and approaches that are fiscally sound, appropriate, and all that to move the science forward. And the last question, consider whether the return of research results might impact healthcare disparities. Well, all the veterans that we service have some disparities, so I assume that that's really a no question. Thank you.